So I hope everyone welcomes me today in joining our very, very special guest, Dr. Robert Rappaport. Dr. Rapaport is a professor of pediatrics at Mount Sinai within the Division of Pediatric Endocrinology and Diabetes. He is the Emma Elizabeth Sullivan Professor of Pediatric Endocrinology and Diabetes. He's also the director of the Growth Center. So Dr. Rapaport received his medical degree from the State University of New York downstate. He then went on to train in pediatrics at Schneider's Children's Hospital and completed his fellowship in pediatric endocrinology at St. Christopher's Hospital for Children, Philadelphia, and in New York's Cornell, New York Hospital. He has published truly countless articles, textbook chapters in his areas of interest, which include growth hormone disorders, children born with SGA, neonatal thyroid disease, growth hormone, immune interactions, and aspects of childhood diabetes and puberty disorders. On a very personal level, he is my son's pediatric endocrinologist. Please welcome Dr. Rappaport. We are very, very excited to have you here today.
Good morning. Thank you all. Thank you very much, Tamar, for this nice invitation. And I see all my friends that are up this early in the morning to see this. I'm very happy to do that. I will start sharing my screen. That I hope you see now. Yes, Tamar, you see that? So I'd like to thank you and everybody else. And actually, I could probably spend the next hour just thanking all my friends in the audience. But I would be remiss to not mention one person in particular, Dr. Case, who has been instrumental in my career at Sinai. So Dr. Case, thank you very much publicly, as I always thank you even privately. So I want to kind of set expectations, just lower expectations as we go through this. And the objective for the 2 hours this morning is, I know, Tamar, it's only 1 hour. Don't look worried. But I'm just saying if everybody knows. So the objectives were to talk about some basics about normal growth in childhood. How do we evaluate the hypothalamic pituitary growth axis that most of you, I'm sure, is very familiar with. And then look a little bit about the FDA-approved indications for growth hormone treatment, some monitoring issues during growth hormone treatment, and then talk specifically a few minutes about the transition from pediatric to adult care in patients with growth hormone deficiency. So this would be the outline. Initial assessment of growth, short stature, and then if we have some time, and probably we will, because I'm in charge of that, emerging treatment options. So why growth? We're so concentrated on growth. Well, and for several reasons. One is that a child's growth is a very important aspect of a general pediatric visit. And it is probably the most common reason why pediatricians refer patients to a pediatric endocrinologist. Dr. Lynn Levitsky in Boston also talked about growth being sensitive indicators of physical well-being during childhood, and also possibly harbingers of later adult disease. Hence, it's not unreasonable to talk to an audience of adult endocrinologists. So we'll start with how do you assess growth and what's normal growth. And for this is really mostly for what, if any, medical students and residents and fellows may be on the program this morning. So the first thing is to measure children carefully, length versus height. Plot them in a curve, look at the weight, look at head circumference, look at bone maturation, and more importantly, to plot them. Longitudinal growth points would be the single most important tool that we have for evaluating growth. Now, this growth point should be appropriate, both for condition as well as for population. So I don't know if I made this too subtle, but this thing over here with a large red arrow, we don't like this floppy signs over there to measure kids. But Tamar, do you ever measure adults? Maybe the weight, right? But not the height. And there's a difference between supine measurement in one of these devices and upright measurement. And we're fortunate that in the growth center, every single exam room is equipped with one of these stadiometers. The person needs to be standing correctly, the feet by there, the face facing forward. So it's important to get good measurements, or else it's difficult to assess growth velocity. They should be plotted on appropriate growth charts. Here's a chart from Usher and McLean where we look for children who may be born small for gestational age, less than 2 standard deviations below the mean. This is a growth curve for patients with Turner syndrome. This is a growth curve if you're in Northeast India, which one of my colleagues sent to me. So it needs to be population as well as the condition specific. When you assess a child for growth during fetal, infant, childhood, and adolescent life, and you look at growth velocity, a rough guide is that you grow 10, 5, 2.5 inches in the first, second, third year of life, but best is to look at growth velocity chart. So growth rate of 5 centimeters may be okay for a 10-year-old, but it's not okay for a 3-year-old. So what are the needs that you need to have in order to grow properly? So globally, nutrition is by far the greatest condition that leads to poor growth. There was a recent article in The Lancet last week talking about hunger worldwide and hunger in children, which leads to poor growth. And that really is something that needs to be eradicated. To grow well, you also need to have a nice psychosocial environment. And any illness, any chronic illness can affect your growth. Cardiac disease, kidney disease. You need to have normal chromosomes. And lastly, normal hormones, including thyroid, pubertal, and growth hormone. So longitudinal growth points are the single most appropriate means of looking at growth. And yes, it starts in utero, where if a fetus does not grow properly, it's called intrauterine growth retardation. Now, short stature, sometimes it's easy to identify, sometimes it's not. And it's really a completely arbitrary definition. If you look at a height less than any of these percentiles, or less than 2.5 standard deviations, growth velocity is if you grow less than average or less than 0 standard deviations, and that will result in impaired stature. So when we do a history, do a good maternal fetal history, perinatal history, try to look at birth weight, birth length, family history, extremely important. History of the siblings, parents, their ethnic background, how tall they are, how old they were when they started puberty. On exam, we look at measurements, and in the child, we look for dysmorphic features, we look for thyroid and pubertal status. And this would be kind of an initial investigation and CBC sed rate and urine. And I always like to give credit to Dr. Donald Gribbets, who was the first one that I know of to describe growth failure as being an indication of inflammatory bowel disease. So we look for celiac antibodies, karyotype in girls, thyroid, and IGF-1. And perhaps in the not near distant future, whole exome sequencing or next generation statistics may be part of the evaluation. So these are the two most common conditions that we see. These children who present with short stature, low height, familial short stature, or constitutional growth delay. There's frequently a family history of it. The key to this is, however, that the growth velocity is normal. What differentiates them is the bone age, which is not delayed in those with familial short stature. It is delayed in those with constitutional growth delay and approximates the height age, or the height at which would be crossing the 50th percentile. If you do nothing, the adult height will tend to be normal, or at least close to normal, in both of these conditions. And I put this star over here because in the past we said that, in fact, there's no treatment, although if you have constitutional growth delayed, puberty hasn't started, you could treat a boy or a girl with pubertal hormones, and it will make them grow somewhat better and not adversely affect the adult height. Growth hormone, I put a question mark, and I put that star because the new definition, which I really hate, of ISS does not exclude any of these two conditions. So here's a child with constitutional growth delayed. He or she grows parallel to the norm, has puberty a little bit later, growth spurt, and winds up in a normal height. Those with genetic short stature grow below it and reach a good height for the family. The question is, why is the family at that height? So that's something we'll need to look at. Puberty is something we always look at because that has a major influence on growth. As you know, boys have a growth spurt somewhat later, almost 2 years later than girls. And this is a growth velocity chart that people should be looking at as well. Here are two other growth charts. So this chart, where I'm pointing right now, a child is small, is getting further and further from the norm. Clearly, the child needs to be investigated. This child who is not catching up, remains short, may also need an evaluation and possibly treatment. So those familiar short stature and constitutional growth delay are the most common causes that we see in short stature. There are many classifications of short stature. This is one of them, not any better or worse than any other ones, but it separates them into proportionate and disproportionate. Disproportionate usually having to do with skeletal issues. Of those proportionate, the question is the onset prenatal? Are these children born small? So anything that affects the mother, placental disease, infections, or affects the fetus, dysmorphic syndrome, genetic or chromosomal disorders can affect the growth. Those children may or may not show adequate catch-up growth. If the onset is postnatal, however, as I mentioned, nutritional, chronic disease, drugs, psychosocial dwarfism, endocrine and metabolic disorders. If you treat the underlying condition, you should be able to reach a good height. So these are some examples of children with dysmorphic features, and many of whom are now candidates for growth hormone treatment. Williams syndrome is not, but Silver-Russell syndrome, Prader-Willi syndrome, Noonan syndrome are all conditions. Now, if this were a live studio audience, I would ask them what these girls have. And this is the original paper by Turner, looking at Turner syndrome. These babies may have this excessive skin growth from resolving cystic hygroma. And I always ask, do they have swelling of the hands or feet in any short girl? They may present with peripheral lymphedema, which usually disappears with age. So let me ask some of my colleagues in the audience, does this woman have Turner syndrome? Who thinks yes and who thinks no? Well,
Maybe. Why did you even comment? Maybe. It's a yes or no question.
Okay, so this woman is Sarah Lady Innes. She was painted by Thomas Gainsborough, and you could see her at the Frick collection in New York City. And the answer is you don't know. So because you don't know, in any short girl, even if she doesn't have any obvious features of gonadal dysgenesis, you should do a karyotype. And that's the point of this slide. Next, we'll switch to growth disturbances, growth hormone, and IGF-1. So this is that, I'm sure all of you know this, but just to make sure that we know what we're talking about, the hypothalamic pituitary axis, and the transcription factor, growth hormone releasing hormone, result in the production of a pituitary gland. And again, there are transcription factors and genes and GHRH genes. But if everything is normal, you have a production of growth hormone, which then goes into the circulation, attaches to growth hormone binding protein, and goes to its receptor on the surface of multiple tissues, in this case, the liver. And then through several different steps, signal transduction, JAK-STAT, and MAP kinase results in production of IGF-1 and IGF-BP3 and acid-labile subunit, and they circulate attached in a ternary complex, eventually going to the end where they need to be at the bone, attached to type 1 IGF-1 receptor. And if the SHOX gene is normal as well, it results in growth. So it's a multiple step process. And you could have abnormalities anywhere along this process. The SHOX gene is in the pseudo-autosomal region of X and Y chromosomes. It does not undergo X inactivation. And you do need 2 normal copies for normal growth. It does affect bone growth, especially chondrocyte proliferation. So the typical person who's missing one of these is a person who's missing a piece of either X or Y, like patients with Turner syndrome. And then next you have this transcription factor, PIT1, HESX1, genes involved in anterior pituitary and growth hormone receptor gene. But if growth hormone is produced normally, it attaches to its growth hormone receptor dimer. It activates the growth hormone GHRH complex and successive phosphorylation events that you see here on the right. And it results in events downstream. STAT is over here, STAT5B. It also affects metabolism. It also affects proliferation. It also affects cytokine signaling, the signal transduction events. So what are the things that we could measure easily? We could certainly measure growth hormone, measure IGF-1, IGF-BP3, acid-labile subunit, growth hormone binding protein, and even a SHOX gene can be relatively easily assayed. So growth hormone, we almost never measure randomly because of this, because it's secreted in a pulsatile fashion in both young and older females and males, and you see many peaks. But if you do it at any random time, a low or a normal value is not helpful. So there are almost 70 different growth hormone stimulation tests, which we use in our center. We use 1 or 2 or 3, and we measure it. So how do you diagnose growth hormone deficiency? Well, first you have a child who's growing slowly, who may be short, who has low IGF-1, low IGF-BP3, and low growth hormone secretion, either spontaneous or stimulated. Any questions here? I guess tomorrow I'll lead you to see if there are any questions in the chat or not, but is there something missing on this chart? The answer is yes. There's no peak value that I put in there because that's a moving target. And growth hormone used to be called deficient if you have a peak level less than 5, then 7, and currently, if you're asked on a board exam, the answer is 10. And I think this is really not related to physiology, but it's related to the availability of growth hormone. The more growth hormone is available, the more to the right this level will go. And just a little cynical. So let me talk to you about the patient. He's a 3-month-old boy with poor growth. He had normal birth weight and birth length. He was breech at presentation, but he had hypoglycemia, jaundice, and a small penis. So in this baby with hypoglycemia, the clues would be jaundice and atypical genitalia. If you measure hormones at a time of low glucose, then it's the best time to measure them because glucose is a very good stimulus for growth hormone and other counter-regulatory hormones. This baby had low growth hormone, low cortisol. T4, T3 were also low without an elevated TSH, could be in the normal range. Prolactin was high, IGF-1 was low. So what would you want to do next? Again, it's not so interactive, so I'll just answer my own questions. So a genetic evaluation can be done to look if there is multiple hormone deficiencies. And certainly we want to do an MRI. And in every single patient who has evidence of a pituitary defect, we do recommend doing an MRI. This baby also had a growth hormone stim test, clearly low, not 5, 7, or 10, but clearly low. And we do look at an MRI, and we do have used to be monthly now, though perhaps less often, that everybody's invited to neuroradiology rounds, where we look at the pituitary gland. This is the anterior pituitary, this is the posterior pituitary, the nice stalk. And we evaluate all of them for potential abnormalities. No, I don't delete that. Okay, here's a baby that actually was my patient who started off pretty normal in weight and length, then did not grow well. Look how far he went ahead. And by about 17, 18 months of age, he started on treatment with growth hormone. So growth hormone treatment, actually, we treated rats before we treated people with beef pituitary growth hormone extract. Human growth hormone was purified in 1956, and in 1958, Rabin published this letter in the New England Journal where he treated an adolescent with growth hormone and showed that their height went up, and he looked at various other metabolic parameters doing this. And now there are many, many companies that are making growth hormone. I'm sure I'm leaving many of them out. It could be given with a needle and syringe, with a pen device, there's a needle-free device. There is no inhaled or transdermal growth hormone, but long-acting growth hormone and oral may be something that we'll discuss a little bit later. And for those of you in adult medicine, we do not recommend any of these, which if you go on the internet, you see all of these compounds. The newest thing is the development of long-acting growth hormone that lasts about 7 to 14 days. Many different companies are making it. Either depot preparation, pegylated, or albumin-bound or a fusion protein. Some of them are already marketed, and some of them are approved, especially for adults, because everything that is developed is first approved in adults. So I'm waiting to see these long-acting oral preparations. So here's an actual patient of mine who here switched from pituitary-derived growth hormone, where he did very well with, to recombinant growth hormone, and wound up pretty good. I could spend an hour just on this one slide alone. When do we start the other hormone replacement? When do we start gonadal replacement? When do we stop growth hormone treatment? Look at the parents, significantly shorter. Look at his weight, significantly high. So growth hormone did not work to manage his growth. So growth hormone treatment, this is summary by Roland Pfeffler. I'll mention some of these. The point of this slide is that the earlier you start, the longer duration of treatment, the better your estimated height gain, anywhere from 1 to 3 standard deviations. And this is an old slide from Mary Lee Vance and Nellie Moraes. And I like it because, number one, it's in color and it allows me to make a point. You grow best in the first year of treatment, next best in the second year, and still grow better than before throughout treatment. And you reach a pretty good height. You see this? It's almost, but not quite at 0 standard deviation. So how can we improve on that? Certainly, we should treat as soon as possible. Should we increase the dose, as many of my patients' parents recommend? And we need to individualize it and look at IGF-1 levels. Or you want to prolong the time of treatment and by doing something to delay bone maturation. And I'll mention some of that later on. So growth hormone is approved for these conditions on the right portion of the slide. In Europe, many fewer conditions, but it includes adult growth hormone deficiency, adults with AIDS wasting. These are the approved indication, and nothing new since 2007. So here's a child who's born small for gestational age. The indications, again, differ between Europe and the United States. The age at which we start 2 versus 4, and the dose, double the dose in the US versus Europe. We do everything larger and bigger. So here's one of my patients. And you may say he's not that short, but he's about close to 10th percentile, but look how tall his parents are. So we treated him with growth hormone for a year, and his height went close to 50th percentile. So are you convinced? Of course not, because that's just one case, and you're all scientists, and So we did a study with first-year predictors in this high dose of growth hormone, multiple centers around the country, about 139 patients. We looked at insulin resistance with, as you could see on the slide. And what we found is that at 1 year, the height increased by about 0.9 standard deviations. IGF-1 went up, but it remained in the normal range. And similar changes were noted in weight as well as BMI. So this very large dose was well tolerated, at least for a year. The delta height SDS was predictive of the 1 year, and the 1 year change on height is predictive of the rest. One of the things that I thought was unusual is that underweight children grew as well as other children, because some people advocate gastrostomy tube and all that to increase their weight. But in this group, those who weren't as lower BMI did just as well. So this patient that I showed you before, in fact, wound up pretty nicely, wound up taller than mid-parental target height. And in fact, the same summary by Roland shows that the earlier you start, the mean age 5 versus 12, you gain more height. And as the duration of treatment, though, you gain from 0.6 to 1.2 to 1.8 standard deviations. But I know you are adult endocrinologists. Why should you care about children born SGA? And that is because how big you are when you're born may be an indicator of future future health. So being born small for gestation age, and this may be another lecture if you like, on non-growth adult correlates of SGA. The weight at birth, the length at birth is related to impaired intellectual development. So the same babies born premature or not, the lower the weight, the more difficulties with psychosocial development. You could look at bone mineral density, Dr. Bergman, you could look at vitamin D and everything else, but in fact, the birth weight correlates with adult bone mass at 64 years of age. Low weight is implicated in impaired lung function in adults, impaired stress response in adults, possibly cancer, and certainly abnormalities of insulin metabolism and the development of this metabolic syndrome. How often does anybody in adult medicine ask their patients about their birth weight and birth length? Actually, it would be a lovely study, Dr. Bloomgarten. You could look at patients in a diabetes population for adults and look at their birth weight and birth length. Now, growth hormone, these are all, and I just want to stress again, these are not FDA-approved indications for growth hormone treatment, but people have used them. Patients with Down syndrome, neurofibromatosis, 18q deletion syndrome. Some have used it for hypochondroplasia. Crohn's disease, there was a patient by Alfred Slonim showing that adults treated with growth hormone did better with their Crohn's disease. Cystic fibrosis, precocious puberty, my colleagues, Dr. New, pioneered this at CAH, have done that. Wound healing, people in Spain were very big at using patients with wounds with growth hormone. We do not recommend for aging and spa treatments, although there's lots of stuff on the internet you could find on the use of growth hormone and various different forms. And I'd be interested in getting this gel and see what's actually in it and used in various spas around the US, Mexico, everywhere. Now, hypochondroplasia, I mentioned, Michel Pollack in France had a cohort of patients that they followed to adulthood. Growth hormone seemed to improve it, but not all that much. And we wrote with my colleague, Dr. Regelman, a little editorial showing that it's really not ready for patients with hypochondroplasia. So the take-home message so far is that for FDA-approved indications, growth hormone works very well. It does increase adult height. The two new things that people are talking about is the growth plate and oral agents for, quote, partial growth hormone deficiency. So these are the targets at the growth plate, and Jeff Barron at the NIH has talked a lot about this C-naturating peptide analog and Maturation. So this person found in a different museum, not in the Frick, has a condition called achondroplasia, which is autosomal dominant, huge penetrance, due to a mutation as the FGFR3 receptor. This activated receptor prevents the proliferation and differentiation of chondrocyte and accelerates chondrocyte apoptosis and impairs linear growth. So people have used, and this now is FDA approved for the last perhaps 6 months, this analog of CNP that is resistant to degradation by this metalloendopeptidase. And it does result in improvement in height compared to previous one. So people are perhaps starting to use this agent for patients with achondroplasia. Maturation-3 is an antibody, an IGF-1 fusion protein, an extracellular matrix protein, which has been used also for patients with difficulties in the growth plate. One of the newest things has been, and there's been around for more than 20, 25 years, Dr. Laron 25 years ago wrote an editorial about this, oral agents that stimulate the production of growth hormone secretagogues. It stimulates growth hormone releasing hormones from the hypothalamus, suppresses somatostatin, so potentiates this GHRH signal at the pituitary, and does rate and growth hormone release. So if you do a growth hormone stim test and your result is like that baby that I showed you one, it doesn't help. But many kids have these intermediate results of 3 to 7 to 8 nanograms per milliliter. Perhaps in those, if you just treat them with this agent, it results in growth hormone production, they may grow better. And we wrote a little editorial about that in the Journal of the Endocrine Science, and we are embarking to do a study at Sinai with this agent. How about IGF-1 treatment? That was approved in 2006. Who should you treat? And should you treat them once a day, twice a day, with or without growth hormone? These answers are still not definitive for now. But this is the actual group of patients for whom this would be the only agent. This was Laron. We wrote this about 25 years experience. These are patients with Laron Syndrome. And you could look for, not sure why it does that. Patients who have problems with the growth hormone receptor, extracellular, transmembrane, or intracellular abnormalities, downstream abnormalities in ERK and STAT5B, or even further difficulties in the growth hormone releasing element, IGF-1, ALS. And this is a summary that Dr. Bright wrote for one of these endocrine clinics. And as you'll see, the number of cases, there are relatively few. There are a few more now, but still in a matter of very, very few patients. Still, let me talk to you about a patient that we had at Sinai. He was 11 when I first met him. He's been followed for growth since he was about 3 years of age. He was diagnosed with growth hormone deficiency in Ecuador at 3 years of age. The history was not complicated. Note, as compared to the other children, his birth weight was normal, did not have, as opposed to the baby I showed you, did not have jaundice, hypoglycemia, or a small penis. His growth rate was low since about 2 years of age. A family history, the mother and the father were somewhat short, but there was no endocrine disorder in the family. His vital signs were fine on exam. Hilo was fine. He did not have a small penis, was otherwise normal pre-pubertal. And look at this growth chart. This lowest line is 5 standard deviations below the mean, and he was below that. And at the age of 2 years, 9 months, he underwent growth hormone stimulation, very low peak, very low IGF-1, normal thyroid function test, and a small pituitary on MRI. And quite correctly, he was started on treatment. And he responded very nicely. His growth rate went up to almost 11 centimeters per year. But then immediately after that, he stopped growing. And treatment was stopped. They measured growth hormone antibodies. And in fact, at 5.5 years of age, she was diagnosed as having a homozygous deletion of GH1. So growth hormone did not work. And then when we saw him, we treated him with IGF-1 in a complex form, and he did somewhat better. Growth rate did go up. But I must tell you, it's not one of our success stories. He is, in fact, one of the patients with isolated growth hormone deficiency, type 1A, autosomal recessive, a gross deletion, microdeletion, or nonsense mutation in this gene, where growth hormone is entirely absent. So the body doesn't recognize it, and it produces antibodies against it. They have severe short stature, and you do develop antibodies as soon as growth hormone treatment is started. There are some milder mutations that may respond to growth hormone. Some condition which is X-linked associated with agammaglobulinemia, and I've had a long interest in growth hormone immune function interaction, and that is a family with that. Growth hormone 1 gene on chromosome 17. So this is how we did with him. He grew somewhat better, but wound up still very short. And we were quite upset about it. And then when we look in the literature, Steve Chernisak and colleagues showed this study, the final height in some of these patients. I prefer to call it adult height, but anyway, some of these patients wound up -5, -8, -6 standard deviations below the mean. And the same was true in Europe, where Michel Pollack and the group looked at that. Much more common than this child is, however, this child that we see commonly is very short. She's very short and had a growth hormone stim test that was normal. Then we rechecked it again, and it was low. We started treating him. And this condition is very common. It's a child who's very short, has normal IGF-1, normal IGF-BP3, normal SHOX gene, normal growth hormone to response. IGF-1, IGF-BP3 may be somewhat low, normal, if anything, somewhat high growth hormone stimulation. Could he have a problem with his growth hormone receptor or post-receptor? Growth hormone binding proteins suggestive of growth hormone receptor was low. But in fact, his growth hormone receptor measured by Andrew Dauber was normal, as was STAT5. What does this child have? The answer is, I don't know. I like to call it growth failure of unknown etiology, or as others call it, idiopathic short stature, which is in fact FDA approved. We wrote a paper last year with Professor Savage and Professor Witt from the Netherlands, how the more you investigate these children, the less patients will be identified as idiopathic short stature. Now, I mentioned these options for better results. Treat those. How do we delay bone maturation? Well, Jack Janowski published his paper in the New England Journal, showed that if you use a GnRH analog, it does increase adult height a little bit, but it does adversely affect the bones. Then there was a seminal paper in 1994 that described an adult who was now 28 years of age, but was still growing. They did a bone age on him, and it wasn't fused. This patient had an estrogen receptor defect. So this was then showed into animal models, estrogen receptor knockouts. So therefore, if you do something to delay that with perhaps an aromatase inhibitor, aromatase is the CYP19 gene expressed in multiple tissues. And this is the paper that started it all, I think. Wickman and Dunkel in Europe used a very potent aromatase inhibitor compared to placebo and found that the predicted height after 18 months was significantly better if you delay bone maturation. Nelly Moras and colleagues, including myself, used a placebo-controlled trial saying that, yes, it does seem to improve adult height potential, but overall, there are insufficient data to support its use. Do we use it? Yes, we do it sometimes, and sometimes it does help. So what are other treatment options? So we talked about growth hormone releasing hormone. Growth hormone could be used, IGF-1, and members of the growth plate. And now I mentioned oral secretagogues. monitor IGF-1, glucose, and other pituitary hormones. GnRH analog, aromatase inhibitor, more data are needed and use with caution if you do use it. But in medicine, first, we want to do no harm. So is it safe? That's why I'm showing you this slide twice. And here are some of the side effects of growth hormone treatment. And I must tell you that they're extremely rare. Irritation injection site, edema, pseudotumor cerebri. Jean-Claude Carrel from France has published something that his colleagues then went and said, no, it's not exactly so. Tends to be quite safe. David Allen summarized this paper showing that in general, growth hormone therapy is safe in children and adults. Shlomo Melmed looked at patients who've had adult as well as childhood growth hormone treatment, showing that in general it's safe. And Albertsson Wickton in Sweden showed that if you adjust for birth characteristics, it is safe. But you're all aware of the association of high IGF-1 levels, especially when coupled with low IGF-BP3 and their association with cancers, breast, prostate, lung, colon, but not in growth hormone-treated patients. And in fact, my colleague, Jaime Guevara from Ecuador, who was here for one of our symposia, showed that patients that he's evaluated in the region of Loja tend to get less cancer and less diabetes than others. So here's this patient that was also an actual patient of mine, who was a twin, was about a head taller, was treated and resulted in excellent height. So when should we stop growth hormone? Should we treat him as an adult? So this is talking now about childhood versus adult onset growth hormone deficiency. I'll focus obviously on the childhood onset. Should we stop it and how? Should we retest when and how? Resume it when and how to transition. So this is a study from Sweet Sadiq and others, but showing that growth hormone, while it peaks around adolescence, is still present throughout life. So you do need it throughout life. My other colleague, Dr. Ron Rosenfeld, looked at patients who had childhood growth hormone deficiency, followed for 8 years after they attained adult height, and they have an increase in subcutaneous fat mass, intra-abdominal mass, decreased bone density, decreased cognitive function. He presented that in 2002 when I was a child. But here's a paper right now, in this year, suggesting the same thing in most patients who had organic growth hormone deficiency. When you interrupt the treatment for 2.8 years, you see the same metabolic decompensation, including effect on lipids and bone mineral density. So what happens? We stop growth hormone treatment for most patients, especially if they have only one hormone deficient. And what do you retest them if they have idiopathic growth hormone deficiency with only one hormone deficient? The vast majority, when we retest them, wind up perfectly normal, which raises the question, what did we treat? But in any event, I'll leave that question. If you have organic growth hormone deficiency and you retest, most of them test deficient. So this is a study from Beverly Piller showing that it depends on what agent you use, especially for adults. Insulin tolerance test versus arginine versus L-DOPA, you need to adjust the peak growth hormone level that you want to look at. Mark Hartman published this some years ago that if you have more than 3 or 4 additional pituitary hormone deficits and a low IGF-1, you may not need to do this growth hormone stimulation test. So therefore, should we resume? And again, the people in Sweden were among the first back in 1993 to show how beneficial growth hormone treatment in adults was. So, but I just showed you a minute ago this association of IGF-1 and cancers. Again, not in growth hormone treated patients. So now should we take adults and increase their IGF-1 levels? Well, it so happens that having a low IGF-1 may not be so good for you either. So this is a paper for Anders Juhl showing low serum IGF-1 associated with increased risk of ischemic heart disease. especially if you have low IGF-1 and high IGF-BP3. So having a low IGF-1 and a high BP3 is also not good for you. So therefore, we do recommend that we stop treatment when the growth velocity is low, or when the bone age is nearly fused, 16 to 17 in males, 14 to 15 in females, and reconfirm the diagnosis. If it's organic, or if you have a gene defect, or if you have multiple hormone deficiencies, you may not do this re-evaluation and re-establish it. And we do, so for these patients, we may just change the dose to the adult growth, which is significantly lower, and you monitor IGF-1. Interestingly, IGF-1 by itself is not a good indicator of growth hormone deficiency in adults. So when we stop for at least 1 to 3 months, and then we stimulate them with one or more tests, we may want to do an MRI if one was done a long time ago. We do DNA analysis. You may want to do a DEXA scan to look at bone mineral density, look at lipid profile, cardiac status, and it would be important to establish good carbohydrate metabolism. So we do like to resume growth hormone at low doses and then titrate. And there's a number of patients that, as you know, we in pediatrics do transfer patients to adults the minute they reach the age of 45. But we do treat very young adults or late teenagers with growth hormone and you titrate with IGF-1 levels. And here's a paper that's just now by Gudmundur Johansson and JCNM. Look at 15,000 growth hormone treated patients who were analyzed for a mean of 5.3 years. And they looked at various abnormalities. Is it safe or is it not? And people have looked at patients who had previous intracranial or pituitary tumor, a consensus statement with all these people, with Margaret Boguszewski as the first author, showing that there's no evidence for an association between growth hormone replacement and increased mortality for cancer. And here's an editorial that Shlomo Melmet wrote, and I don't know if it's out already. I guess it may be since it's June 2nd, talking about adult growth hormone replacement, which improves lean body mass, reverses obesity, enhances quality of life, improves bone mineral density, and looking at extensive surveillance studies, including salt fluid retention, carpal tunnel syndrome, hyperglycemia, arthralgia, all of which have been described. They may unmask thyroid or adrenal dysfunction. And it's mostly in patients who are more than 45 years of age and those who have adult onset growth hormone deficiency, seen much less frequently in the childhood onset growth hormone deficiency. The adverse events rate was not proportional to the growth hormone dose. And most importantly, looking at cancer rates showed that the new malignancy onset was not increased compared to the general population. And this is from the editorial that you will see in JCENM that Shlomo Melmet wrote. In fact, for adult growth hormone deficiency, once weekly growth hormone has been used and in some cases already approved. There are some papers that also talk about growth hormone for patients with combined deficiency to induction of spermatogenesis. So with this, I think I've covered most of the objectives I showed at the beginning. The factors for childhood growth, hypothalamic pituitary growth axis, FDA-approved indications, monitoring issues, and some of the ongoing newer therapies, and a little bit about transition from pediatric to adult care. And Emily told me to stop about 5 to 10 minutes before, so I will stop.
Thank you so much, Dr. Rappaport. That was a fantastic.
Okay, and I will not show you this kid who turned out to become this guy. All right, so I will stop sharing and see if anybody has any questions.
Okay, so.
Yes.
So Hi, yeah, so great talk. Thank you very much. My questions actually relate to hormones and growth a little bit. And so I guess one question and one query for speculation. So my question is about evidence for growth differences between males and females that are not sex hormone connected. And how much is there, or is there any? And the second is if you'd care to speculate on strategy. I'm thinking of transgender kids, specifically transgender boys, so female to male. Let's say beginning with a puberty blocker around 10 or 2 or 3 or so, and then what our strategy might be to maximize growth, because at that, typically, we're seeing with those transgender boys that they've had a little bit of a female puberty and end up shorter. So
it's a great question and a great speculation. The question I don't know the answer to, but we know, for example, in prepubertal children where their hormone levels are almost identical, there is a difference already. So if you plot a girl on a boy's growth curve, she'll wind up much shorter. And it's not related to sex hormones because none of them is making any hormones. Testosterone is not produced, estrogen isn't produced. It would be actually fascinating to look at 1,000 prepubertal girls and boys and look at their growth hormone dynamics, which nobody has done and likely nobody will do. Talking about how do we affect adult height is sometimes very difficult. And in fact, we have girls who want to go the other way, want to be trans, and they're horrified of how tall they are. And it's very difficult to stop their height. And we have several patients who are girls who want that stop. So the improvement, and the people in the Netherlands have talked about how to improve the growth in transgender children. One is to stop the puberty, but I don't think growth hormone has been used very much for them routinely. And until there are some studies done, I would kind of agree with that, because with many of the complications and psychosocial issues that arise, I'm not sure that growth hormone should be introduced unless it's part of a well-constructed study. But I think that's something that should be
done. Dr. Rappaport, can you just to circle back a little bit, you had mentioned the link between SGA and metabolic issues later on in life.
Right.
A little bit about the mechanisms at play there,
so the start of that was with a paper by Barker. Some call it Barker hypothesis. And what he did is he did growth hormone. He did a glucose tolerance in 64. Somehow 64 seems to be a good age, and 64-year-old adults. And what they found is that those who had a lower birth weight had an impaired glucose tolerance that's much more commonly than those who had a normal birth weight. The question is why, and has led people to speculate on this called Thrifty gene hypothesis, showing you get during times of famine, for example, it leads to more carbohydrate intolerance later on. So the idea that there was intrauterine, quote, starvation, and the babies are born somewhat smaller may lead to that. It's really a very hot and controversial topic. So it's unclear exactly what the main mechanism is. For example, I was fascinated that some of these patients at 64 years of age had impaired bone mineral density compared to the general population, even though vitamin D levels were the same, everything else was the same. So it seems that there is an effect that is birth size related that may manifest later on. On the other hand, on the good side of things, that happens in a minority of such children that grow up, and the majority do catch up, and the majority do very well.
Thank you so much. It looks like we have a...
Dr. Levine.
Oh, sorry.
Hi, Alice.
Hi. That was great. It was really just great. I had to be here all these years to hear you give a talk. First time.
You see, that's how long it took your division to invite me.
Yeah, it was
No,
worth
no,
my
no,
sticking around here this long.
I'm just joking.
It was really great, Rob. Thank you. I have a very quick question, which I don't know will be practical. I generally, in adults, I only give growth hormone therapy if they're on full hormone replacement, you know, because they had a pituitary tumor and still not feeling well. And I do it the lazy way, because as you showed, if they have 3 or 4 other hormone deficiencies, their IGF-1 is low, I don't have to test them. What if I would have to test them? What is the gold standard test nowadays?
Well, so interestingly, the adult literature talks about the gold standard being the insulin tolerance test, which actually I did when I was a fellow, 225 years ago. But now I would never recommend the insulin tolerance test. It is fraught with danger. It's not something that I'd want to do. I would refer to the paper by Beverly Biller, which showed different agents to use. And one of the studies that we'll be doing, which in fact was done first in adults, is using this massimorelin as an oral agent to stimulate growth hormone to see if that may be a good agent.
What's the name of it?
It's called massimorelin. It's
Okay.
I think I say it right. And we'll be doing a clinical study in the patients who will agree to have multiple growth hormone stimulation tests done. So I would do that. But I think the ones that we use now is arginine infusion, which is quite safe. L-Dopa, if one could get it, and we use glucagon.
Great. Thank you.
Alice, this is Jody. I don't know if you can hear me or not. I'm not turning my screen on, but in patients who have had pituitary tumors or other insults to the pituitary, if they're known to be pan-hypopit with all the other hormones, and they just have a low IGF or one stimulation study, even the insurance companies will approve growth hormone because it's assumed, you know, whereas if they just have one hormone deficiency or none, then you have to be more rigorous in proving growth hormone deficiency. But for insurance purposes, if you're deficient in everything else and you have one test. I had one question, though, that I put in the chat box that maybe Rob could answer in reference to Josh's question about the trans people and the influence of sex hormones. And that is, in the olden days, and I think there's studies that show this, if you add estrogen before doing a growth hormone stimulation study with anything, insulin or GRH or whatever, it augments the response of growth hormone to that stimulus. So how does that fit in
Rhoda,
with what Josh was talking about?
So Rhoda, as usual, you brought up several controversial topics. One of them is whether or not we should do a growth hormone stim test and whether we should pre-treat them with either estrogen or testosterone. And Dr. Yao and I have a paper that will be coming out in Frontiers in Pediatrics showing that it depends on what the question that you're asking. And certainly using estrogen or testosterone will, in most patients, but not all, increase the growth hormone level following stimulation. The point that I think we try to make is that before you do a test, you need to know that you really want to do the test. So you need to select the patient, especially in pediatrics. I don't know about adults, but you need to select the patient. And once you're ready, that if you want to act on the result of stimulation test, that's when you should go ahead and do it. We don't routinely pre-treat them because, you know, it seems that it depends on the question that you ask. On the other hand, another paper I published with Dr. Yao looked at pubertal patients who had their own stimulation with testosterone, who did about the same and had the same percentage of abnormalities as those who were pre-pubertal. Regarding the other thing that you mentioned, isolated growth hormone deficiency, is really fascinating. Is there such a thing as isolated idiopathic growth hormone deficiency? And we have very few children who have only growth hormone deficiency. Upon the retesting, they remain deficient. And and there are a few papers that have been written in the adult literature, but is there such a thing as having an adult with just isolated growth hormone deficiency? I think that would be quite unusual, quite rare, but not impossible.
And Josh's patients that are transitioning from male to female and the fact that they're given estrogen, and then, you know, if they're prepubertal or going through puberty, is that going to impact their clinical response to the growth hormone that Josh theoretically might be giving them?
I think the answer to your question is yes, but I'm not sure, Dr. Safer.
Well, I don't have an answer.
Okay.
I'm listening to you.
I mean, in short-term stimulation studies, it makes a difference. I was just wondering whether clinically long-term administration makes any difference in outcome. But thank you for your answers, and thank you for your talk. Great talk.
Thank you. Okay, it's now 9:30. Thank you very much.
Thank you so much, Dr. Rappaport.